Now, welcome to welcome to our adjourned master class of the API ICP West Bengal. Now, I request one of our course directors, Dr. Satyabrat Ganguly, to introduce chairperson.
Thank you, Professor Banerjee. Mine have a pleasure to introduce my younger brother, Sunip Banerjee, to you. Sunip is a very brilliant student from Calcutta Medical College. He did his MBBS from there, then MD and DM from Chandigarh. Now he is practicing as a consultant cardiologist in one of our specialty hospital, Ruby. One thing which I mentioned to Sunip, he is both clinically and the intervention cardiologist, both there's a balance in him. So he is so much popular among the doctors and among the students. So I request Sunip to chair the session. Thank you.
Thank you, Professor Ganguly, for those kind words. I see many important teacher figure for me, Shivendu, Amol, apart from that, Dr. R.N. Sarkar. So I'll just take 2 minutes to introduce the subject as it is basically for the students and for us also. Before Dr. Manjunath describes this entities on valvular heart disease, we need to remember the
Shuri, one thing I request you, before you introduce the subject very briefly, you just introduce Professor Manjunath also.
Professor Manjunath is a figure in cardiology from the southern part, from our student life even. And he practices in the Jayadeva Institute and is the director there for a long time. He has a vast experience on this subject, the clinical and the valvular heart disease, apart from the newer interventional and structural heart diseases. So it is important for us all to get a idea from what we are going to have. And my last word will be on this subject before we come to the conclusion or concluding remarks or discussion, is we need to remember how we used to finish the diagnosis. That is the background etiology of the valvular heart disease, rheumatic or congenital, and then what is the severity of the disease, the most important and the intelligent aspect of it to pick up the mixed valvular heart disease, and then the NYHA class, the rhythm and associated heart failure or infective endocarditis. So if you want to diagnose all these things, you need to have a very clear grip on the theoretical background, the natural history, and a meticulous assessment. So next 1 hour or so, Professor Manjunath is going to do that task in a case-based approach. So we are eager to hear from him. Professor Manjunath, all is yours now.
First of all, I'm very thankful to the chairman, Indian College of Physicians, Dr. Amal Kumar Banerjee, and the West Bengal API chairman, H.S. Pathak, and Dr. Sunip, who is going to be the chairperson. So I will just take you through regarding the clinical evaluation assessment, and because decision making is very important, whether it is structural, any subject, it's not just cardiology, discussion and the decision making is extremely important. And we always, there are popularly, I talk about decision making is more important than intervention, and decision making is more important than incisions, number 2. And the treatment should not be harmful than the disease. So these basic 3 things we should keep in mind always whenever we are talking about any illness. So that is the reason still the clinical skills are extremely important. Despite explosion of intervention, despite explosion of technology, still clinical assessment is the basic foundation of evaluation of any diseases, and cardiovascular disease is no exception. So this is just a background. The valvular heart disease is commonly encountered in clinical practice. Proper assessment of individual lesion is important. Not necessarily all lesions will be equally severe or equally moderate. Decision making more often differs from cardiologists to surgeons, and timing and type of intervention and surgery is very important, and cost and long-term outcomes are also should be kept in mind. Understanding the hemodynamics and consequence of one lesion on the other is also equally important, because whenever we are dealing with valvular heart disease, more often than not, we see multivalvular involvement. So one lesion is going to have an impact on the other. The clinical findings and symptoms usually determined by flow, pressure gradients, ventricular function. These are important things. And rhythm and pulmonary hypertension. These 4-5 important things should be kept in mind, because, for example, in mitral stenosis, the gradient is driven by heart rate as well as by the flow, and ventricular functions are very important in regurgitant lesions. And rhythm is also important, because many valvular lesions do have atrial fibrillation, ultimately pulmonary hypertension. Presence of a proximal lesion leads to underestimation of a distal lesion. For example, patient has a mitral valve disease, also has got an organic tricuspid valve disease. Upstream disease will have impact on the clinical assessment. We normally underestimate the distal lesions. For example, mitral stenosis is underestimated in presence of tricuspid stenosis or tricuspid organic tricuspid regurgitation. If you look at the etiology of multivalvular heart disease, rheumatic heart disease is the most common. And of course, degenerative things as the lifespan has gone up. Definitely, aortic valve disease is more often degenerative, then followed by bicuspid and rheumatic. And mitral annular calcification can be part of degenerative mitral valve disease. Endocarditis involving multiple valves. Uncommon causes are Marfan syndrome, collagen vascular disease, carcinoid syndrome, radiation storage disorder. Some drugs can cause valvular heart disease. So this functional classification is extremely important whenever we are talking about clinical discussion, clinical evaluation, whether it is undergraduate, whether it is broader specialty, or whether it is super specialty. This NIHA classification is the basic thing. Every one of us should be well aware of that. Just for the benefit of our students, I'm just going to repeat this. NYHA class 1, there is no limitation of physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, and dyspnea. Then we have class 2, that is, there is a slight limitation of physical activity, but the ordinary activities results in fatigue, palpitation, and dyspnea. Then we have class 3, so that means less than ordinary activities produces these symptoms. There is a marked limitation of physical activity, that is class 3, and 4, of course, they are symptomatic at rest. So without discomfort, they can't carry out any physical activity. So this is extremely important. You should keep it in mind throughout your lifetime. So then this is the clinical approach that you already said. So then coming to the causes, I already briefed about the causes of valvular heart disease. Then we'll move on to case 1. Here is a 38-year-old female presented with exertional dyspnea from last 5 years in functional class 2, now progressed to functional class 4 for the last 2 months. So just look at it again. Exertional dyspnea for 5 years and worsening in the last 2 months, and associated with palpitation, and history of paroxysmal nocturnal dyspnea was present, no history of rheumatic fever. So given this history, of course, other things we wanted to know here, whenever a patient present with this sort of symptoms, we need to know, is there any history of hemoptysis? Because that is also an important thing. Or is there any history of hoarseness of the voice? Why this is very important is sometimes whenever there is significant pulmonary arterial hypertension, the dilated and a tense pulmonary artery can compress the left recurrent laryngeal nerve, and it can give rise to hoarseness of the voice. That is the reason. So this is the scenario. So looking at this history, we need to, historically, we need to know about the differential diagnosis. Whether is it rheumatic heart disease? Yes, it's still a possibility. It is a rheumatic heart disease because nearly 50 to 60% of patients with rheumatic heart disease, established rheumatic heart disease, need not give history of rheumatic fever. So rheumatic heart disease has to be kept in mind. And Dr. Sunip, should I go on discussing the differential diagnosis or you are going to intervene? Because I wanted to know what exactly the practice.
Actually, Manjunath, you go on discussing. At the end of our discussion, the PGTs will show their questions in the chat box. Then,
Okay.
Okay.
Okay, fine. So that's fine. So with this history, female, exertional dyspnea. So paroxysmal nocturnal dyspnea always points to a left heart failure. Either it could be a left ventricular failure or it could be a left atrial failure. For example, if it is mitral stenosis, the left ventricle is well preserved, but still patient gets a paroxysmal nocturnal dyspnea. So that is the reason history of paroxysmal nocturnal dyspnea really separates out whether it is cardiac or whether it is non-cardiac, because sometimes exertional dyspnea can be also part of a lung disease. It could be a chronic obstructive lung disease, or it could be an interstitial lung disease, or some sort of an infiltrative lung disease. So one has to differentiate. So history of paroxysmal nocturnal dyspnea, that means they go to sleep, then within few hours of getting to the sleep, they will get up with breathlessness, and of course they try to sit or they try to go near the windows and all those sort of things, and it takes some time to settle down. So the differential diagnosis of paroxysmal nocturnal dyspnea, many a time obstructive sleep apnea can be confused. Some people come to us, they get into sleep, they start snoring, then they get up. So one has to differentiate between PND and obstructive sleep apnea. And also postnasal drip also can cause some sort of a picture. I'm just giving a differential diagnosis for PND. So then other history can, if somebody asks you with this history, can you give a differential diagnosis? One is, says it's a rheumatic heart disease and patient must be having raised left atrial pressure. So it could be, definitely there is some element of pulmonary venous hypertension. It could, or another differential diagnosis, whether it could be a mitral regurgitation at this point of time. So mitral regurgitation, chronic mitral regurgitation, PND is not a very early symptom. In chronic rheumatic mitral regurgitation, PND comes little later, but it could be a combination of both. It could be a combination of mitral stenosis along with mitral regurgitation. It could be a combination of both. That is the second possibility you should always keep in mind. And the third possibility, just you can ask, suppose if this being a lady, whether she has got some sort of an iotoarteritis. Even iotoarteritis can also give rise to a valvular lesion. They can have exertional dyspnea or a PND. And if you are thinking about cardiomyopathy in this age group, 30 to 40 years, yes, even hypertrophic obstructive cardiomyopathy can present with dyspnea, can present with palpitation. So these are the possibilities you should always keep in mind in this. So we'll move on to the, of course, this lady has 2 kids, and the last kid was about 10 years old, and there was no problem during pregnancy. And because always these things should be kept in mind whenever you are dealing with a female with this sort of symptoms. So we will move on to the examination. The pulse is 150 per minute, irregularly irregular. So what are the causes of irregularly irregular pulse? The commonest cause is atrial fibrillation. And the second one is sinus arrhythmia, which is very common in youngsters, sinus arrhythmia. And the third one is, yes, varying AV block. Varying AV block can also give rise to irregularly irregular pulse. And the blood pressure obviously was 100/60. It's on the lower side. And jugular venous pressure. I think this is a very, very important component of clinical examination. And of course, we have various methods of examining the JVP, 45-degree angle, all those things. The best way, I think, just sitting position or standing position if you see a JVP column above the clavicle in sitting or standing, that means it is raised. That is a very simple thing, because clavicle is a constant landmark. It doesn't change with the posture, unlike your other usual method of assessing the JVP. And see, there is a difference between raised JVP and a prominent waves. There can be a prominent A wave with a normal jugular venous pressure. So these two components are important. And always make sure if patient is in atrial fibrillation, A wave has to be absent. So sometimes we contradict patient. On one side we say patient has got atrial fibrillation and A wave is present. No, it doesn't go, because atrial fibrillation means atrial A wave is absent. Then coming to a cardiovascular examination, apical impulse is in the left fifth intercostal space in mid-clavicular line. It is tapping in nature. That means neither it is hyperdynamic, neither it is heaving, but it is just felt. It is just felt. And in fact, earlier used to call it as snapping, the snapping for sound, something like that. Then left parasternal heave, and P2 was palpable in the left second space. So left parasternal heave and palpable P2 always suggest this patient must be having some significant pulmonary arterial hypertension. Then on auscultation, the S1 was loud and it was variable in intensity, and P2 is, see, when in this all you just finish off sounds, then come to the murmurs. So sometimes we mix up sounds with murmurs. So initially you start with the sounds, but sound was loud here and it was variable in intensity, and P2 was also loud. Normally, P2 is not heard in the mitral area. If you are hearing a P2 in the mitral area, that obviously means patient has got a significant pulmonary arterial hypertension, number one. There is only one exception. In absence of pulmonary arterial hypertension, P2 can be heard in the mitral area. Two exceptions. One is your large ASD. Second is a small kid, because precardium is so small, it can have this thing. Then opening snap was present, and the A2os interval was narrow even during the long cycles, and there was a long rumbling mid-diastolic murmur at the apex, and this is very, very important. It was a long drawn mid-diastolic murmur. I mean, it's almost pan-diastolic, and respiratory examination, bilateral course crepitations. So with these findings, the diagnosis is rheumatic heart disease, severe mitral stenosis, severe pulmonary venous hypertension, severe pulmonary arterial hypertension, atrial fibrillation with a fast ventricular rate, and patient is in heart failure and functional class 4. And of course, this patient also had some mild tender hepatomegaly also. It was not really tender. There was a mild enlargement of the liver. And there was, in addition to this finding, there was grade 2 pansystolic murmur along the left sternal border. So there could be, so patient has severe MS, severe PAH, and the patient has got mild to moderate tricuspid regurgitation, atrial fibrillation with a fast ventricular rate. So having made this diagnosis, so you will be always asked to substantiate and justify the severity of the lesion. Why do you say mitral stenosis is severe? Is it because of loud first sound? No. Loud first sound is nothing to do with the severity of mitral stenosis. Only if the first sound is loud, it only suggests that the valve is pliable, it is not calcific, and there is no significant subvalvular disease. Only three things the first sound says. Loud first sound rules out a significant calcification, rules out severe subvalvular disease, and also rules out any associated mitral regurgitation, all those things. So then why do you say mitral stenosis is severe? We say mitral stenosis is severe because it was a long mid-diastolic murmur. That means the gradient was persisting between left atrium and left ventricle throughout diastole. That means that is suggestive of significant mitral stenosis. That is one point. Second one is this A2os interval is short. What is this A2os interval? If mitral stenosis is severe, obviously left atrial pressure is high, and if left atrial pressure is high, it opens the mitral valve early. As a result, opening snap occurs early. So a shorter the A2os interval, severe the mitral stenosis, longer the mid-diastolic murmur, severe the mitral stenosis, and severe pulmonary hypertension also suggests towards severe mitral stenosis. So these are the important things, because in the examination we keep hearing, whenever we ask them, how do you say severe mitral stenosis, they always tell loud first sound, loud first sound. No, loud first sound only suggests it's a pliable valve. So this is all about mitral stenosis. As I can see here, fish mouth appearance because commissural fusion occurring, so also caudal fusion, and these are some of the causes of mitral stenosis. We all know that, so I will not get into too much of theory. Only thing I wanted to tell, nowadays, following a mitral valve repair, if it is a very enthusiastic, aggressive mitral valve repair, it can result in mitral stenosis. That we have seen. Rarely it can be a degenerative mucopolysaccharidosis, radiation, and carcinoid syndrome. Carcinoid, as we all know that it always affects the right heart valves, but if it is a pulmonary carcinoid, it can always affect the left heart too. These are some of the things. And mitral stenosis, commissural involvement is 30%, cuspal 15%, caudal 10%, combined. It's more often combined. So look at this. So if somebody asks you, how do you make a diagnosis of rheumatic mitral stenosis, because there was no history of rheumatic fever, you look at this. The history of rheumatic fever you don't see in 50%, and it can be seen absent in females up to 80%. Absence of rheumatic fever history does not rule out a rheumatic heart disease. So these are some of the important symptoms: progressive exertional dyspnea, PND, and acute pulmonary edema, and nocturnal cough, wheezing, hemoptysis, winter bronchitis, and rarely there can be a chest pain, particularly what you call it as when patient develops severe pulmonary arterial hypertension, right ventricular hypertrophy. There is a right ventricular angina. We used to call angina cerullosis, something like that. And if patient is in atrial fibrillation, there can be systemic embolism and hoarseness of the voice. I will come to that. See, earlier used to this nomenclature of Arton syndrome was that is dysphagia, and patient has got, hoarseness of the voice. Typical of, it was described in relation with mitral stenosis. But today it is broadened. The nomenclature is changed. Instead of Arton syndrome, we label them as cardio-occult syndrome. That means not necessarily this hoarseness of the voice can develop only in mitral stenosis. It can develop in pulmonary hypertension of any cause. Even an Eisenmenger syndrome can give rise to hoarseness of the voice. Earlier explanation was dilated left atrium is likely to compress the left recurrent laryngeal nerve, resulting in hoarseness of the voice. No, because left atrium is a posterior structure. When it enlarges posteriorly. It is unlikely to compress the left recurrent laryngeal nerve. So compression of the left recurrent laryngeal nerve is due to a dilated and a tense pulmonary artery because of high pulmonary artery pressure. So pulmonary hypertension of any cause can give rise to hoarseness of the voice. Hence, nowadays, nomenclature is cardio-occult syndrome. And of course, the symptoms of right heart failure is basically fatigue. See, I think this one should understand. The dyspnea is always due to, paroxysmal nocturnal dyspnea is always due to pulmonary venous hypertension or elevated left atrial pressure. And fatigue is due to reduced cardiac output. When a patient of mitral stenosis develops a right heart failure, that results in decreased cardiac output. So fatigue is a symptom of right heart failure. Can you develop syncope in mitral stenosis? Whenever you are dealing with a case of mitral stenosis, and if there is an history of syncope, suspect aortic stenosis, because in presence of mitral stenosis, you can underestimate or miss aortic stenosis, and contrary is also true. In presence of aortic stenosis, you can miss mitral stenosis. So that is the reason you are dealing with a case of aortic stenosis, If patient has disproportionate PND, suspect mitral stenosis, or if patient has got atrial fibrillation, suspect mitral stenosis in presence of AS. In presence of MS, when do you suspect AS? History of syncope, history of angina, you have to suspect. So this is how you have to evaluate and dissect your decision. And can you get syncope in mitral stenosis? Extremely rare. It could be then valvular thrombus in left atrium can be a rare cause of syncope, or even left atrial myxoma can present exactly clinical features of mitral stenosis. So patient has got mitral stenosis symptoms, syncope is also an important symptom, then you can think of a valvular thrombus or rarely what you call left atrial myxoma. We will not get into too much of theoretical aspects. We have to, yes, juvenile mitral stenosis, we all know about it. Nearly in our series of about 10,000 cases of mitral stenosis, what we have analyzed. In fact, we at Jaideva, over last 15 years, we have conducted nearly 30,000 balloon mitral valvuloplasty. This is one of the highest series in the world. 30,000 mitral valvuloplasties have been done. In our series, nearly 20% of them were under juvenile MS category. And what are the special features of juvenile mitral stenosis? In other words, mitral stenosis in the young, below 18 years of age. So they are more fibrotic and less of calcium, and no calcium or less of calcium, and sinus rhythm, because it's quite a younger age group presentation, and fibrotic valve is severe submitral disease, and atrial fibrillation was also rare. And this is what, of course, in the last 4 years, we are seeing less of mitral stenosis in our center. So we'll move on to ECG. What are you expect in an ECG of a typical rheumatic mitral stenosis with pulmonary hypertension? You look at this here, a right axis. A right axis always suggests patient has got severe pulmonary arterial hypertension. Even based on the axis, you can also assess severity. If the axis is more than 60, plus 60, then mitral stenosis is severe. If axis is less than 60, then mitral stenosis could be moderate. That is one. And if axis is further rightward, like 110 or more than 100 degrees plus, then pulmonary arterial hypertension must be severe. So this is the importance of axis. And of course, in this patient is a sinus rhythm. You look at this valve, P wave. P waves are broad and notched. Broad and notched P wave always suggest left atrial enlargement. Broad and you can see here. And also you come to V1, negative P terminal force more than 1.5 and 30 millisecond in duration also suggests left atrial enlargement. This patient has got a right axis. This patient has got a left atrial enlargement. Because why I'm telling this, see, the early part of the P wave is due to right atrial activation. The later part of the P wave is due to left atrial activation. Because there is a significant left atrial enlargement, there is a notched P wave because intra-atrial conduction is prolonged. And so this patient, so this ECG is consistent with the diagnosis of pulmonary mitral stenosis because there is a left atrial enlargement. And again, patient has got severe pulmonary arterial hypertension. You can see here, there is R waves. So monophasic R waves, even R waves are still persistent, T wave inversion. So if you see R waves with T wave inversion or ST depression, that means patient has got a significant pulmonary arterial hypertension. In other words, there is a pressure load of the right ventricle. So what do you expect in a chest X-ray in severe MS? Yes, obviously left atrial enlargement. See, you can see here, this is the left atrial appendage. Left heart border is formed by, you can see here is your aortic knuckle here. Then comes left atrial appendage. So there is the features, radiological features of left atrial enlargement. Number one is dilated left atrial appendage and double atrial shadow. You can shadow in shadow. This is the left atrial border, shadow in shadow. and widening of the carinal angle. Carinal angle is widened. So these are all suggestive of left atrial enlargement. Then you can see prominent upper lobe veins. Prominent upper lobe veins, pulmonary veins suggest pulmonary venous hypertension, and dilated pulmonary artery here. Right descending pulmonary artery is dilated, suggesting pulmonary arterial hypertension. And you can see curly B lines at cardiophrenic angle here at the base of the heart, suggesting long-standing pulmonary venous hypertension. Rarely, of course, a right ventricle, yes. So if somebody asks you, is there any right ventricular enlargement, you should always ask, right ventricular enlargement is best studied in the lateral view. So in the PA view, it is difficult to really comment on the right ventricle. So this patient has got left atrial enlargement and pulmonary venous hypertension, pulmonary arterial hypertension, and so it is all consistent. Rarely calcified valve can be seen in a penetrated view. Here it is not calcified. And long-standing cases, of course, nowadays most of them underwent intervention, either valvoplasty or surgery, depending on the valve morphology. And long-standing untreated mitral stenosis can have reticular pattern, what is called pulmonary hemosiderosis. Of course, it's not here. That is just for a description. So these are the echo findings you can see here. This is left atrium, this is aortic valve, this is left ventricle. So it's a typical, you can see here, restricted mobility of the anterior mitral leaflet. There's a dooming of the mitral valve. And on the right panel here, you can see color flow, candle flame appearance. Why candle flame appearance? There is a turbulence across the mitral valve, resulting in a candle flame appearance. And there is also some amount of mitral regurgitation. See, when mitral regurgitation is mild, there may not be auscultatory systolic murmur. So this patient has got rheumatic mitral stenosis, and mitral valve area is really severe, tight. Sorry, I think, okay, because these are all moving images, sorry. So this is a parasternal short axis, very typical fish mouth appearance. Fish mouth appearance, and anterolateral commissure is open, but little bit of calcium here. But at the level of commissure, it is fine. Although there's a bit of calcium, commissures are free. So other things you should always look in mitral stenosis is whether there's any left atrial thrombus, whether there's any mitral regurgitation, because that will decide about the strategy of treatment. So based on the gradient, we always say mitral stenosis is mild when the gradient is less than 5, and moderate between 5 to 10, and severe more than 10. So these are some of the classifications we have done in left. So actually, the left atrial thrombus was a contraindication for balloon mitral valvoplasty, but if the thrombus is confined to appendage or just above the fossa ovalis, if it is organized, still we can do. So indications for balloon valvoplasty means, yes, the patient should have a severe MS, number one. See, there is a difference in the definition of severe MS between American Heart Association definition and our Indian. They say between mitral valve area between 1 to 1.5 is considered as severe as far as American ACC/HA classification. But in India, because our body surface area is less, so even 1 to 1.5 for our body surface area is considered moderate, and anything less than 1 is considered severe, and anything less than 0.5 is critical. I think these are, I will not get into too much of interventions. Balloon mitral valvoplasty contraindications is LA body clot and grade more than grade 2 MR if it's a calcified valve and lack of expertise. See, this is an LA appendage clot. So we can always do this. You have to, I mean, you have to do a procedure in such a way you don't maneuver much in the left atrium. We have our own technique. over the wire technique, which is named after me also, and I will not get into that. So these are some of the pictures. Left atrial thrombus. So this is a contraindications for balloon mitral valvuloplasty, low heart left atrial thrombus. So also if the clot is along the atrial septum also we won't do. So this is how balloon mitral valvuloplasty is done. So the complications of balloon mitral valvuloplasty may be small percentage, 2.5% can develop acute MR requiring valve replacement. Otherwise, it's a standard thing. You can see this is the valve after the procedure, both the commissures are split. So I think I will stop at this stage. So if there are any questions, I can take it or I can move it on. Dr. Sunil?
There was some questions. Mostly I have answered. You can see in the chat box.
Okay.
But probably we can go ahead and then.
Okay, fine. So look at this picture. This is a patient of rheumatic mitral stenosis, has got ascites, massive ascites. So whenever you come across a picture like this, you have to suspect an organic tricuspid valve disease. Or if the heart is silent, no murmurs, then your other differential diagnosis has to be a constrictive pericarditis. Or of course, their abdominal causes, I will not get to that. I mean, it could be tubercular abdomen, or it could be malignancy and all those sort of things. Always, whenever you are dealing with a case of rheumatic mitral valve disease, and if patient has got ascites, massive pedal edema, markedly elevated JVP, or pulsatile liver, think of organic tricuspid valve disease, whether it could be an organic tricuspid regurgitation or it could be organic tricuspid stenosis, because nearly 5 to 6% of patients with rheumatic heart disease had an organic tricuspid disease. So this lady had both mitral stenosis as well as tricuspid stenosis, and invariably these people will have jaundice because of long-standing hepatic congestion or systemic congestion. So let me move on to case 2. Here's a 35-year-old female. Predominant history is palpitation at rest for last 6 years, increasing on exertion, and palpitation was regular. And it was mainly regular, and fatigue and dyspnea on exertion from the last 3 months, and she is in functional class 2. See, in the earlier case, more or less similar, but the predominant symptom was exertion, paroxysmal nocturnal dyspnea, and also the exertional dyspnea. Here, palpitation is a most important symptom. Whenever a patient presents with history of palpitation, which is regular, so at the same time, we should ask whether palpitation is at rest or whether it is on exertion. What is palpitation by definition? Abnormal awareness of one's own heartbeat is called palpitation, because normally we don't feel our heartbeat. If you are feeling your own heartbeat, then it qualifies for the definition of your palpitation. And what are the causes? What is the mechanism of palpitation? See, palpitation could be due to arrhythmia. It can be, in fact, if patient has got ectopics, it can give rise to palpitation. Or if patient has got extreme bradycardia, because of increased stroke volume, you can get palpitation. Or if heart rate is very fast, also you can have palpitation. Then they are different from structural heart disease palpitation. A volume overload of right ventricle or volume overload of left ventricle can also is an important cause of palpitation. Because in mitral stenosis, there is no volume overload, so palpitation is rare in mitral stenosis. And while in mitral regurgitation or aortic regurgitation, or for that matter, RV overload conditions like ASD, left to right shunt situations, yes, you can get palpitation. So here is a patient presenting predominantly with palpitation, and again, there is no history of rheumatic fever, and she has gone through that pregnancy without much problem. Suppose if somebody asks you, suppose if the lesion was already present during pregnancy, would it not exaggerated the symptoms? Always obstructive lesions become worse during pregnancy, whether it's mitral stenosis or whether it is aortic stenosis. So the obstructive lesions worsen during pregnancy, while regurgitant lesions are well tolerated during pregnancy. Even a patient with chronic severe MR, patient with chronic severe AR with a normal LV function pregnancy is well tolerated. So in this case, patient has got palpitation. So probably it is due to volume overload, whether it is due to mitral regurgitation or whether it is due to aortic regurgitation. We are not sure at this stage. If somebody asks you whether palpitation is because of right ventricular volume overload, yes, possible. What are the causes of right ventricular volume overload? One is ASD or your TAPVC or PAPVC, and all those things can be a causes of palpitation. But another important symptom here is fatigue and dyspnea. Fatigue, what does it suggest? Fatigue always suggests a decreased cardiac output. So between mitral regurgitation and your RV volume overload, because in mitral regurgitation, there is also decrease in the cardiac output. What is happening in mitral regurgitation? Left ventricle is pumping into two chambers. That is, left ventricle is ejecting the blood into aorta. At the same time, is also pushing the blood into left atrium. As a result, there is a decrease in the cardiac output. The combination of palpitation and fatigue and dyspnea point more towards the mitral regurgitation as far as history is concerned. So there is no history of hoarseness of the voice. And again, historically, there is no significant evidences in favor of pulmonary arterial hypertension. So this is the examination. Pulse is 86 per minute regular, and it is 126 by 78. And it is a normal volume pulse or little brisk pulse, I can say. Apical impulse is in the left sixth intercostal space. Obviously, there is a cardiomegaly, half an inch lateral. It's both down and out. It is hyperdynamic in nature. What is the difference between hyperdynamic and heaving type of apical impulse? Hyperdynamic apical impulse is there is increase in both amplitude and not in duration. Hyperdynamic apical impulse means, yes, it lifts your finger, but the duration is normal, but amplitude is more. Then what is heaving apical impulse? In the heaving apical impulse, both the amplitude as well as duration has increased. So heaving apical impulse or a sustained apical impulse you get in pressure overload like aortic stenosis or systemic hypertension or hypertrophic cardiomyopathy. While hyperdynamic LV apical impulse we get in mitral regurgitation or in aortic regurgitation. So again, I repeat, hyperdynamic apical impulse increases in only amplitude, not in duration, while heaving apical impulse increases both in amplitude and duration. Then coming to auscultation, of course, this patient did not have any left parasternal heave, and pulmonary artery pulsations was very feeble in left second space. On auscultation, S1 was soft, and it was S2 was widely split and variable. That was, it was moving with respiration. It's not a fixed split, and it was a wide split. And P2 was reasonably loud, and there was a third art sound was felt, auscultated at the apex, and there was grade 3 pansystolic murmur in the mitral area going to the apex. So these are some of the important physical findings. Patient has got down and out apex. It's an LV type of apex. It is a hyperdynamic apex. S1 is soft and S2 is widely split. And there is an S3, LV S3, and P2 is loud. Pansystolic murmur heard along the, heard maximally at the apex, going towards the axilla, and there was a faint, short mid-diastolic murmur at the apex. So there are no other findings. There was no murmur in the aortic area, or there is no murmur along the left lower sternal border, suggesting there is no tricuspid regurgitation. So with this physical findings, we can fit into the diagnosis of chronic severe mitral regurgitation. Why do you say severe mitral regurgitation? Number one, there is cardiomegaly. Always whenever you are dealing with cardiovascular assessment, cardiomegaly is very, very important finding for quantifying regurgitant lesions, very, very important, or even for shunt lesion, for example. ASD, VSD, PDA. When do you say large ASD, large VSD, large PDA, there has to be a cardiomegaly. So even in regurgitant lesion, cardiomegaly is a very important thing. It's a hyperdynamic apex. Then another, why do you say it is severe MR? Three important things to say patient has severe MR apart from cardiomegaly, that is second heart sound was widely split. Why second heart sound is widely split? Because LV is pumping into LA, left atrium, as well as into aorta. As a result, LV ejection is shortened and A2 occurs early. So A2P2 interval increases. And third heart sound, because there is an increased flow, and because of increased flow, there is a third heart sound. And also an increased flow also produces a faint mid-diastolic murmur. So all these points towards severe mitral regurgitation. So the diagnosis is chronic rheumatic heart disease, severe mitral regurgitation, and mild pulmonary arterial hypertension in sinus rhythm, functional class 2. So these are, will not get into the too much of theoretical aspects. So these are some of the things we should always remember. Symptoms of rheumatic severe MR develop late. They have a long asymptomatic period. Palpitation is because of volume overload. Fatigue, I've already said, because there is decrease in the forward stroke volume. Dyspnea and pulmonary hypertension has got a late presentation, occur later. Infective endocarditis can also one of the important complications. Infective endocarditis in mitral stenosis is very, very rare because it is a low pressure system. Mitral stenosis, it is a diastolic gradient, and it is mitral valve opening is in a low pressure system, while in mitral regurgitation, it is a high pressure system because LV blood is getting into LA at a very high pressure. That means LV systolic pressure is like your systolic blood pressure. LV systolic pressure is about 120. So with a 120 millimeters of pressure, the regurgitation is taking place across the mitral valve. As a result, more turbulence, infective endocarditis can be a cause of mitral regurgitation or could be a consequence of mitral regurgitation. So these are some of the clinical features. Apical impulse, of course, other physical examination, if you carefully see in chronic severe MR, you can get a third space pulsation due to dilated and pulsate left atrial appendage pulsation. Heart sounds in MR, I've already said. Three important things. Again, I repeat, S1 is soft, S2 is widely split, and US3. S1, S2, S3. You keep it like that. S1, S2, S3. S1 is soft, S2 is split, widely split, S3 is heard. So it is all severe MR. So systolic murmur, always it's a pansystolic, it's radius to the axilla and sometimes to the back in chronic rheumatic MR, because here the AML, anterior mitral leaflet, is predominantly involved in chronic rheumatic MR. That is the reason your systolic murmur is radiating towards your axilla and back. But if it is a PML prolapse, and because sometimes we see other causes of mitral regurgitation is mitral valve prolapse. If PML is prolapsing, resulting in MR, it goes towards more towards the aortic area and to the right second space. Sometimes you can have a severe MR, but murmur is not that audible, particularly if it is part of dilated cardiomyopathy or if it's an acute MR. In an acute MR, you don't get a pansystolic murmur because there is a very fast equalization of LV and LA pressure. As a result, murmur is very short in acute MR. Also, and of course, in paravalvular leaks in patients with prosthetic valve, you may not get a very impressive systolic murmur. So, what do you expect in an ECG in a patient of chronic severe MR? Obviously, because there is left ventricular enlargement, you can see here tall R waves and also Q waves and upright T waves, suggesting of LV volume overload. LV volume overload, how do you say? Tall R waves, Q waves, and T waves, upright T waves. So question is, can a patient of chronic severe MR can develop an ST depression and a T wave inversion? But this can happen when patient develops LV dysfunction. When a patient of severe MR develops LV dysfunction, you can get ST depression or some sort of a pressure overload pattern. And digitalis also can give rise to an ST depression. Keep it in mind. If patient is on digitalis, and digitalis can also cause an ST depression. And yes, this patient has got LV volume overload and upright T waves. So if it is a pressure overload, in aortic stenosis, ECG is different. Tall R waves, there you will get ST depression and T wave inversion. Axis is also here, probably it is going towards right, but not that much, as around 80. And left atrial enlargement is not very impressive in this ECG. This is what, see, ECG sensitivity for left atrial enlargement is around 40%. One should not think just because there is no left atrial enlargement on ECG, that doesn't mean patient doesn't have a left atrial enlargement. And this is how the ECG looks. X-ray, this is a typical X-ray of chronic severe MR. You can see here, massive cardiomegaly, CT ratios around 75. And you can see here, the left atrial appendage is enlarged. Of course, this is not a very good exposure because it's underexposed. That's the reason we are not seeing the double shadow of the left atrial enlargement. And this is an LV type of apex. See, how do you say apex is LV type or RV type? See, in LV type, it dips. The shadow dips into the diaphragm, while in RV type, it's lift. So I think earlier, some of our teachers used to say kick or kiss. If it is kissing, then it is LV type. If it is kicking up, it is an RV type. And also pulmonary arterial hypertension is not much here. And of course, pulmonary veins are prominent, suggesting patient has pulmonary venous hypertension. So you can see his apical fourth chamber here. Left atrium is huge. In fact, that's what's seen on X-ray. Left atrium is huge, almost 8 centimeter, and left ventricle is enlarged. It's hyperdynamic, and you can see on color flow there is a severe mitral regurgitation. It's wall lugging. It's almost occupying more than 60% of the left atrial area. In fact, this is prolapsing. You can see here. This is anterior mitral leaflet. This is posterior mitral leaflet. One of the scallops of the PML is prolapsing into the left atrium. These are some of the examples of ischemic MR. See, the difference between mitral, because rarely mitral valve prolapse can be also due to rheumatic heart disease. So only the difference is here leaflets are thick, while in a primary mitral valve prolapse, leaflets are very thin and pliable. So here you can see here the left ventricle is poorly contracting, while in the seminar case, it was briskly contracting. So this is a typical of ischemic MR with severe LV dysfunction. So indications, what do you do for this case? So definitely this patient has got a prolapse of the mitral valve, and it's not that typical of rheumatic history. It's not, I mean, leaflet was not that thickened. So most likely it could be a mitral valve prolapse with severe mitral regurgitation. So indications for surgery based on number one, symptoms. If patient is symptomatic, we have to subject for, in this case, it is either a of course, the anatomy is suitable for mitral valve repair. So if the anatomy is not suitable, if leaflets are heavily thickened and it is tethered to the posterior wall, then we have to replace the mitral valve. So the indications for surgery in chronic severe MR, number one is symptoms, and or if patient in asymptomatic patient, if LV function is reduced, or if pulmonary artery pressure is more than 50 at rest. And these are some of the indications. So 3 indications. Number one, if patient is symptomatic, or in absence of symptoms, if patient has got severe LV dysfunction, or if patient has significant pulmonary artery hypertension, or if patient is undergoing surgery for other valve, then also it has to be corrected. So this is just a bit of a history, I mean, theoretical history. Involvement of mitral valve in rheumatic heart disease is around 84%. Aortic valve is involved in around 29%. Both aortic and mitral valve were involved in 24%. In fact, people say, yes, isolated aortic valve involvement cannot, involvement cannot occur in rheumatic heart disease. No. See, clinically, it could be rarely it could be a dominant rheumatic aortic valve involvement. If you do echo, there is thickening of the mitral valve. There may not be clinical evidence or severe mitral stenosis or mitral regurgitation. So this is another, in another 5 to 8%, there can be clinically significant rheumatic aortic valve involvement, either aortic regurgitation or aortic stenosis, but clinically mitral valve involvement was not there. But echocardiographically could do, there is an rheumatic evidence of mitral valve involvement is there. So this is a study we just published in Indian Heart Journal long back regarding the patterns of involvement of the valve in rheumatic heart disease. What is the frequent combination? The most common combination of rheumatic valve involvement is MS-MR. Second one is MS-AR. Third one is MR-AR. Then fourth in that order is aortic stenosis and regurgitation. Fifth is AS with MR, and least is MS and AS. The most common type of pattern of involvement in rheumatic heart disease is MS and MR. Then we have MS and AR. That is the most common multivalvular disease we see. MS and AR. Least is MS and AS. Least is MS and AS. And which is the worst combination? Worst combination is AS and MR. Worst combination is AS and MR because in aortic stenosis, LV pressure is very high. It could be around 150 and 200 systolic millimeters of mercury. Because in aortic stenosis, LV pressure is so high, and if there is mitral regurgitation, this 150 or 200 LV systolic pressure is transmitted to LA because of mitral regurgitation, resulting in severe symptoms of pulmonary venous hypertension and heart failure. So we'll move on to case 3, history. 78-year-old male presenting with hypertension, type 2 diabetes, and exertional angina, class 2 to 3 for last 1 year, 2 episodes of syncope on exertion, and dyspnea has really worsened in the last 2 months from class 2 to 4. So 3 important components in this case. One is, yes, patient has got an angina, syncope, and breathlessness. So this is a typical symptoms of LVOT obstruction, or in other words, aortic stenosis whether it could be a valvular aortic stenosis, or it could be subvalvular, or what we call it as an hypertrophic cardiomyopathy type of valvular LVOT obstruction. So let me see. So whenever you come across this sort of symptom, angina, syncope, or along with dyspnea, we have to think of an LVOT obstruction, either in form of valvular stenosis, aortic stenosis, or in form of LVOT obstruction. If somebody asks you, can a coronary artery disease present like this? Because he is diabetic, he is hypertensive, plus he is 78 years. So he is one of the best candidates for obstructive coronary artery disease. Coronary artery disease, of course, angina is a typical feature of obstructive coronary artery disease. And dyspnea also, rarely syncope is also could be a manifestation of coronary artery disease. Just because patient gives a history of syncope or dyspnea, you shall not rule out a coronary artery disease. If there is a left main critical stenosis, patients can have dyspnea. Apart from angina, can have dyspnea because as he keeps walking, ischemia of the left ventricle occurs, LV and diastolic pressure goes up. As a result, pulmonary venous hypertension also develops and they get dyspnea. In fact, dyspnea is one of the worst symptoms of obstructive coronary artery disease. It always suggests that patient must be having a proximal obstruction either in left anterior descending artery or in the left main itself. Can a patient of coronary artery disease develop syncope? Yes. A left main patient, if there is a severe obstruction, patient can develop syncope. It could be due to arrhythmia, or it could be a severe LV dysfunction, and dyspnea can be always, and fatigue also. In fact, patient with proximal coronary artery obstructions can develop what is called fatigue towards the end of the day. Fatigue towards the end of the day also point towards. So at this point of time, I keep both the possibilities in mind. Patient is elderly person, diabetic, hypertensive, and has got angina, exertional dyspnea. So also 2 episodes of syncope. So my differential diagnosis, either it is an LVOT obstruction, say whether it could be a valvular severe aortic stenosis or a severe LVOT obstruction in form of hypertrophic cardiomyopathy. Third possibility is an obstructive coronary artery disease. It could probably a left main disease, or it could be a severe proximal LV. So keep it in mind, syncope can also be a symptom of coronary artery disease. So coming to examination, pulse 72 per minute, pulsus parvus et tardus. So it's a slow rising pulse. Blood pressure was 100/74. So pulsus parvus et tardus means it's a low volume and slow rising pulse. So it is always, so at this point of time, if somebody asks you, could it be hypertrophic obstructive cardiomyopathy? Because historically we thought whether there could be an hypertrophic obstructive cardiomyopathy. No. In hypertrophic obstructive cardiomyopathy, pulse volume is good and it has a spike and doom pattern. It is a rapid rise. So pulse itself will differentiate whether it is valvular stenosis or whether it is hypertrophic obstructive cardiomyopathy. Then coming to palpation, inspection, okay. I mean, palpation, heaving apical impulse. Again, I have said the previous case, it was hyperdynamic. That means it was increasing in amplitude, not in duration. But heaving apical impulse here, it was increasing in both amplitude and duration. And heaving apical impulse always suggests a pressure overload. What is pressure overload? That is obstruction at the aortic valve or obstruction in the LVOT. Even systemic hypertension can also give rise to a heaving apical impulse. S1 is soft and S2 is single, S4 was present. S4 always suggests decreased LV compliance. Any hypertrophied LV, any LV which is decreased in compliance produces S4. So just for discussion, what are the situations where you don't get S4? S4 you don't get in atrial fibrillation because it's the atrial contribution. S4 you don't get in atrial fibrillation. S4 you don't get in mitral stenosis severe, because this has to be transmitted to the LV through the mitral valve. If there is an obstruction, severe mitral obstruction, you don't get S4. You don't get S4 in atrial fibrillation. So two things you should not tell when the patient is having atrial fibrillation. One is A wave is absent, S4 is absent. A wave and S4 go together. A wave and S4 go together. In atrial fibrillation, you should never say A wave present or S4 is present. Both are absent in atrial fibrillation. So then there was a grade 3 to 4 ejection systolic murmur with late peaking was heard both in the right second space as well as what we call it as a second aortic area. Left third space, we call it as a second aortic area. There was this murmur, but it was best heard in the right second intercostal space. In fact, our tendency, our threshold for auscultating right second space is very low. Whenever you ask you to auscultate, the tendency is to auscultate only mitral area, tricuspid area. We always forget about right second space. So you should always make it a point to really examine and auscultate right second intercostal space. Otherwise, you are going to miss aortic stenosis. So ejection systolic murmur with late systolic peaking was present in the right second space. It was grade 4. That means obviously with a thrill radiating to both the carotids. So which is the best place to look at the pulse also? You can always pulses parvus yet tardus are best felt in the carotids. So what are the pulses which are best heard at the periphery is your what do you call your collapsing, your pulse, particularly the collapsing pulse. Yes, you can appreciate in the thing, and your pulses alternance. Pulses alternance is also best felt at the radial, while your pulses parvus et tardus is best felt at the carotids. So what is your diagnosis with this? See, this patient has a Ewing apical impulse, and also systolic pressure was low, and there was a grade 4 ejection systolic murmur with a late systolic peaking, and there is also an S4, and of course split was not there. Normally in severe AS you can get always a paradoxical splitting of the second out sound, which was not there. So with this background, and there was pulses, slow rising and low volume pulse, slow rising, slow volume pulse, heaving apical impulse, and a late systolic peaking murmur in the aortic area, and heaving apical impulse, all points towards severe valvular aortic stenosis. And considering his age, it's a degenerative calcific aortic stenosis and functional class 2, and of course hypertension and diabetes mellitus. So this is how we can see here. I think this looks like a bicuspid, only 2 cusps here. It's more bicuspid aortic valve and with the calcification. You can see here one cusp here, another cusp here. So the causes of aortic stenosis, rheumatic, in our series, 8 to 10% of aortic stenosis was rheumatic, and this patient did not have clinically mitral valve involvement, but mitral valve involvement was evident on echo. There was thickening of the mitral valve. And second is bicuspid aortic valve and degenerative 12% over 75 years. So that means rare causes, familial hypercholesterolemia, radiation, rheumatoid arthritis, Paget's disease, ochronosis. We have seen 5 to 6 cases of supravalvular aortic stenosis in patients with familial hypercholesterolemia, because the degenerative aortic valve is also a part of atherosclerosis. That's what the extension of atherosclerosis into the aortic valve. So angina in aortic stenosis is due to reason. It could be due to associated coronary artery disease, or it could be because LV hypertrophy, there's a mismatch between the supply and demand. And as a result, and also the coronary perfusion pressure is reduced. These are some of the causes of angina. Angina, it could be because of either a mismatch between supply demand or because of associated coronary artery disease. In our series, 8% of patients below 60 years had obstructive coronary artery disease in patients with aortic stenosis, only 8%. Of course, with the increasing age, if there are multiple risk factors like diabetes and hypertension, then the prevalence of coronary artery disease is much more. Syncope on exertion is occurs in 15 to 30%. The mechanism of syncope in aortic stenosis is works on what is called mechanemoreceptors, because LV pressure is so high in aortic stenosis, it could be 200 or maybe 250. So that sends contradictory information to the brainstem that, see, there is a very high pressure developing in the cardiac chambers. As a result, the pressure drops disproportionately. So there is what is called peripheral vasodilatation, resulting in syncope and fixed cardiac output. Two causes of syncope. One is fixed cardiac output and activation of mechanoreceptors, sending contradictory information to the brainstem to really reduce the pressure in the system. And third one is profound peripheral vasodilatation. So this is what I have already said. And murmur. See, why, based on auscultation, if somebody asks you, why do you say severe aortic stenosis? It's a, you have to quantify, it's a long ejection systolic murmur with late systolic peaking. So if ejection systolic murmur is confined to early and mid systole, then it is only mild to moderate aortic stenosis. If ejection systolic murmur is peaking late into the systole, it's very simple. If aortic stenosis is severe, then the gradient persists throughout systole as a murmur. As a result, the murmur is a longer one, and a late systolic peaking is a auscultatory synchronon of severity of aortic stenosis. Of course, in this case, we did hear another murmur in the same murmur with a different frequency in the mitral area, what is called Gallavardin phenomena. It's a long systolic musical high frequency murmur of calcific AS heard at the apex by mimic MR. So this is because the frequencies are filtered and the thickened leaflets. See, you hear this musical quality only when the leaflets are a little bit moving. If the leaflets are already fixed, you don't get this musical murmur. In this case, there was a high frequency murmur, Gallavardin, that means with a different quality, different frequency, the murmur of right second space versus murmur of mitral area was heard in this. So ECG is a typical, see, in the previous case, it was a case of severe mitral regurgitation. It was a volume overload. In that volume overload, we see, yes, we had an LVH ECG, but the T waves are upright. Here, volume overload is there, tall R waves, and ST depression and T wave inversion. So there's a pressure load. No doubt there is an LV hypertrophy, but it is a pressure overload. So that's the reason I have picked up these two cases, because the previous one was a volume overload, where R waves, in both the cases, R waves are upright R waves, I mean tall R waves in V5, V6, but you look at this ST depression and T wave inversion suggests it's a pressure overload that is typical of severe aortic stenosis. So LVH, loss of ST depression and T wave inversion. Chest X-ray in aortic stenosis with normal LV systolic function is almost normal because it's a concentric hypertrophy. While in a volume overload, you get a eccentric hypertrophy, there will be LV dilatation, and as a result, cardiomegaly is a feature of aortic regurgitation. Cardiomegaly is a feature of mitral regurgitation. But cardiomegaly is not a feature of severe aortic stenosis. But if you look carefully here, you can see, of course, CT ratio is normal, but LV contour is convex. Convex LV contour suggests that patient has got a concentric left ventricular hypertrophy. You have to carefully, then you can see here, ascending aorta is dilated. So what if somebody asks you, is it a rheumatic valvular aortic stenosis? My answer is no, because in rheumatic aortic stenosis, aortic root dilatation doesn't occur. It occurs only in bicuspid aortic valve or in this sort of situation. So aortic, this is how each one of these investigations provide a lot of information. That is the reason clinical evaluation is still the cornerstone of your assessment of a valvular lesion and also decision making, because I repeat, decision making is more important than incisions, decision making is more important than intervention, and 80% of your diagnosis can be accurate if you follow all the sequence of your evaluation. So here is a case you can beautifully seen, LVE, I mean no cardiomegaly. If somebody casually look at this X-ray, say it's normal except for little aortic dilatation, no. So that's the reason many times we keep listening to postgraduates or even to some consultants, or X-ray is normal. I said no, if X-ray is normal, if there is a long ejection systolic murmur with late systolic peaking, it's a typical. So convex, this sort of picture you can get even in hypertension also. Convexity of the left lower border suggests concentric LV hypertrophy, because concentric LVH means the thickness of the ventricle increases, cavity is reduced, so there is no cardiomegaly, and ascending aorta dilatation usually doesn't occur in rheumatic valvular stenosis. So this is left atrium, left ventricle, and the LV contractility is reduced, valve is hardly opening. Gradient is huge. Based on gradient, we assess the severity, categorize the severity of AS. If mean gradient is more than 40, we say severe AS. And if the P gradient is more than 70, we say severe AS. Here the P gradient is 108, where is severe aortic stenosis, and patient has got LV dysfunction also. See, despite LV dysfunction, this patient has got a gradient of 108. If LV function were to be normal, this gradient would have been 150. So indications for aortic valve surgery, yes, one is symptomatic severe AS, or in absence of symptoms, indications for surgery in AS is LV dysfunction or extremely high gradients like 125, systolic gradient 125, or if patient is undergoing other valve surgery or a bypass surgery. Of course, TAVI, I will not get into that. Nowadays, it has emerged as one of the important alternate therapy for elderly aortic stenosis. Then probably I will take another 5-10 minutes and close this, because we have another 10-15 minutes time. Case 4, 29 years male, history of dyspnea, functional class 2, again palpitation and history of nocturnal angina, pounding sensation in the chest while at rest. So palpitation, yes, patient has got nocturnal angina. This was a typical of aortic runoff. It could be due to, it could be due to aortic regurgitation, or it could be due to, because aortic runoff is different from aortic regurgitation is one of the common cause of aortic runoff. Other causes of aortic runoff, rupture of sinus of Valsalva to right ventricle or to right atrium, or rupture of sinus of Valsalva can also rupture into left ventricle. Another important thing here, why nocturnal angina? Because during night time, heart rate drops, and you know that coronary filling occurs during diastole, and because there is a aortic runoff, there is stealing of the blood from the coronary circulation, resulting in angina. See, not necessarily every patient of aortic regurgitation should get nocturnal angina. A regular angina also they can get, because again increase in the muscle mass and it is the diastolic gradient drives the coronary flow into the subendocardium. The what is called your perfusion pressure. Perfusion pressure is the difference between your LV end-diastolic pressure and the aortic diastolic pressure. You know that aortic diastolic pressure can be very low in aortic regurgitation. And pounding sensation in the chest means because of vigorous contraction. Because stroke volume in aortic regurgitation is huge, and that causes abnormal pulsation. Even various neck pulsation can give rise to pounding sensation. So this patient had a morphinoid hepatus. There was a iridogenesis, pulse was 110, collapsing in nature, and wide pulse pressure was there. And the apical impulse was in the seventh space, seventh intercostal space, 3 centimeters. So it was really down and out, and it was hyperdynamic in nature. Again, increase in apical impulse was increasing in amplitude, not in duration. While in aortic stenosis, yes, it is only, it's both amplitude and duration. Here it's only amplitude and LV. Then coming to auscultation, there was an early diastolic murmur heard in the left third intercostal space, occupying more than then what happens? Yes, somebody can ask you whether there is an associated organic mitral stenosis. It is unlikely here because there is no significant pulmonary arterial hypertension. Because in aortic stenosis or in aortic regurgitation, pulmonary hypertension develops very late in the course of the disease. And second one, the pulmonary hypertension develops very late, and the S1 is again soft here. Usually S1 in isolated image, obviously it will be loud. Then there are some maneuvers to differentiate whether this murmur of mid-diastolic murmur heard at the apex, whether it is due to aortic regurgitation, what you call it Austin Flint, or whether it is because of mitral stenosis. So we can give just to give sublingual nitroglycerin, or what you call your isardil or your this thing. It causes peripheral vasodilation, and if it is due to aortic regurgitation, then this murmur, mid-diastolic murmur heard over the apex, decreases in intensity. If it is due to mitral stenosis, because after few cycles the venous return increases, there is increase in the mid-diastolic murmur. This is one. Or isometric hand grip. With isometric hand grip, actually the Austin Flint murmur of AR increases, while that of MS murmur decreases. So again, most important is if pulmonary how do you suspect mitral stenosis in aortic regurgitation? If patient is in atrial fibrillation, suspect mitral stenosis. Or if patient has got severe pulmonary arterial hypertension, suspect mitral stenosis. So indirectly, we can also come to this sort of conclusion, because sometimes when there is a free-flowing murmur of early diastolic murmur of aortic regurgitation, this murmur is heard all over the place. It's very difficult to hear your mid-diastolic murmur over the apex. So this was a of course, I have not gone into all those scale markers or the physical signs of your wrist sign, your dolichomania, or the various somatic signs of Marfan syndrome that you people are well aware of those. Severe aortic regurgitation, and there is LV dysfunction, functional class 2, and sinus rhythm. So these are chronic AR symptoms: palpitation, both rest, exertional, increased sweating, warm flush skin due to marked systemic vasodilatation, angina, exertional, and either nocturnal or exertional, dyspnea, late manifestation. But when once this aortic stenosis and they have a long asymptomatic period, when once they become symptomatic, they have a rapid downhill course. This bispherians pulse, wide pulse pressure with low diastolic, these are all, I think there are more than 24 signs of aortic regurgitation. I will not get into that. So Hill sign, when the pressure difference between the upper and lower limb is more than 60, such as severe. And maybe, so when do you don't get an ill sign in a patient of aortic regurgitation? When patient develops severe LV dysfunction, your ill signs may not be that impressive. In an acute AR, it may not be obvious. And if there is a upstream obstructive lesions, sometimes you may not get it. So these are some of the exceptions for ill sign. Then S3 indicates LV dysfunction. See, S3, loud S3 in mitral regurgitation suggests severe MR, while S3 in aortic regurgitation suggests LV dysfunction. Yeah, of course, in this case, there is an aortic root dilatation. And if AR murmur is heard better to the right of the sternum, then it is due to aortic root dilatation. See, in rheumatic or in other non-aortic root dilated, the early diastolic murmur is best heard to the left of the sternum. If there is an aortic root dilatation like Marfan syndrome or other collagen vascular diseases, annulo-aortic ectasia, the early diastolic murmur is heard to the right of the sternum. This is described by one sign called Harvey sign. That's the reason. Clinically, you can know whether aortic regurgitation is due to aortic root dilatation or whether it is due to primarily valve morphology. So if the early diastolic murmur is heard best to the right of the sternum, always think it is due to aortic root dilatation. In that case, it could be formifrosty of Marfan's or annulo-aortic ectasia, or it could be due to bicuspid aortic valve with aortic root dilatation. ECG in chronic severe AR is almost same. You can see here LV volume overload, tall R waves in V5, V6, and upright T waves. See, in aortic stenosis, there was ST depression and T wave inversion, but in aortic regurgitation, it is all about tall R waves, deep Q waves, and upright T waves. Can a patient of chronic severe AR develop ST depression? Can a patient of chronic severe AR develop T wave inversion? Yes. Towards the later part of the disease, when they develop severe LV dysfunction, or if they have an obstructive coronary artery disease, they can develop an ST depression and a T wave inversion. Is it possible to differentiate if ECGs are given? One ECG of a chronic severe MR, another ECG of chronic severe AR, both are volume overload. Is it possible to differentiate between the two? Yes, it is possible to differentiate. In chronic severe AR, the S waves are deeper in V1, V2. While in chronic severe MR, S waves are not that deeper in V1, V2. That is how, because V5, V6 will not able to differentiate between these two. So if there are deep S waves in V1, V2, and it's a LV volume overload ECG, think of AR. And if LV volume overload picture is there, if S waves are not that deep in V1, V2, think of MR. This is some, I think this has already been published in various articles. You can see here a massive cardiomegaly, LV contour, CT ratios increase, and no much pulmonary venous hypertension. So you can see here, LA is not much dilated, mild MR, but you can see LV is dilated, and this is a massive regurgitant jet is going from aorta to LV, severe aortic regurgitation. Another important thing here, down below you can see this AR jet is hitting the mitral valve, resulting in what is called flutter. So the mechanism of mid-diastolic murmur heard in chronic severe AR, because this AR jet is hitting the mitral valve, it is not allowing the mitral valve to open completely. As a result, there is some gradient developing across the mitral valve. That is one of the important reason. See this here, very interesting finding here. Aortic sinuses are markedly enlarged, typical of your Marfan syndrome, and it is virtually compressing the left atrium. And you can see this whole aortic sinuses is almost 8 centimeters. So this is a typical color Doppler feature of AR. LV is enlarged, LV is contracting well. That means still LV dysfunction has not set in. So this is so in this sort of a case, the indication obviously is straightforward surgery. It has to be aortic root replacement itself, but I mean both the valve as well as the root has to be replaced. So with this, I have come to the conclusion of this particular topic. Only thing I wanted to highlight, these are some of the echo pictures of always in mitral valve disease, always you should assess tricuspid valve, very, very important, because a patient has got severe tricuspid regurgitation. If you don't correct tricuspid regurgitation, if you correct only mitral valve, then the symptoms will not improve. Patient continues to have symptoms. Then finally, so these are the important things. Again, we have to keep in mind whenever we are dealing with rheumatic heart disease, etiology, the combination and severity assessment, whether patient has got pulmonary hypertension or not, whether rhythm is sinus, atrial fibrillation, whether patient is heart failure, functional class, whether there is any rheumatic activity undergoing there. I mean, whether any infective endocarditis, and LV function. This LV function is, and RV function also. It's not, in fact, all the time we are talking about LV function, even RV function is as important as LV function, because LV function is, RV function is bad, then outcome of mitral valve replacement is bad. And precipitating factors, this is what I wanted to highlight before concluding my talk. What are the precipitating factors where a moderate lesions can become very symptomatic? Anemia is one of the most common thing. 40 to 50% of our patients have anemia, and you must be knowing what is the definition of iron deficiency anemia. Hemoglobin less than 13 in men, hemoglobin less than 12 in women, sorry, hemoglobin less than 12 in women, and your transferrin saturation less than 20%. Those are the definitions of iron deficiency anemia, because I had seen many patients coming with the moderate mitral regurgitation, moderate aortic regurgitation, extremely symptomatic. Hemoglobin is 6 grams, and you correct that hemoglobin, they become absolutely all right, because our present day generation writes more HbA1c investigation than HB investigation. HB is as important than HbA1c, because always they write HbA1c first. In my opinion, hemoglobin should be written first. Anemia is one. Atrial fibrillation. I will just give an example. Patient has got moderate metastenosis. His heart rate is 80. And if his heart rate increases to because of atrial fibrillation or because of exertion, if a heart rate of a moderate mitral stenosis patient increases from 70 to 150, he becomes extremely symptomatic, because at a heart rate of 150, that mitral stenosis behaves like a severe mitral stenosis, because gradient is driven, because of tachycardia, diastolic period, filling period is reduced, and LA pressure goes up. There is incomplete emptying of left atrium, resulting in pulmonary edema and get into all complications. So anemia is an important thing, and atrial fibrillation with a fast ventricular rate, then your endocarditis, the rheumatic activity, thyrotoxicosis, pregnancy. These are some of the, and even alcohol, all those are important precipitating factors. So I think the clinical evaluation is very, very important. There's a very popular saying that you should examine, at least first time you should examine very systematically with 10 fingers and both the hands. That's very, very important, because I think all the time we are trying to treat, because of modern day gadgets, we are treating investigations, we are treating images, we have to treat the patient. Who is an average doctor? Who is a good doctor? See, average doctor is one who treats the disease. A good doctor is one who treats the patient. Patient, in addition to the disease, has a lot of other problems. So with this, I thank the Indian College of Physicians as well as API West Bengal for this opportunity. I'm very happy to share my views about all these things. And if there are any questions, we can always take it.
Yes, thank you, sir. So, Professor Manjunath, thanks again for this elaborate and clear description of these complex issues. And I think we all have been benefited with this lecture. There are many questions I have answered mostly. There are two last questions. One is how you stamp case 3 as a degenerative aortic stenosis. So what you said in case 3 as a diagnosed as a degenerative aortic stenosis.
Degeneration on a bicuspid valve.
Yes. So that's the important thing, and many a time it may not be possible to know that the bicuspid valve, if it is too much calcified, it may be a perioperative finding only, or by MRI you can pick it up, or CT scan. The other thing is Dr. Shivendu Ghosh has asked, tempo in Indian rheumatic heart disease differ from Western countries. So what is your opinion, sir, on these issues?
Yeah. See, one thing, probably, of course, in Indian scenario, rheumatic heart disease is aggressive. See, we have seen the youngest rheumatic heart disease patient requiring surgery as early as 7 years, 8 years. In fact, I have seen a rheumatic mitral stenosis at the age of 6 years. So the interval between the onset of rheumatic fever to the time of established rheumatic heart disease requiring surgery in the Western scenario, it's very long. They present at the age of 30 years, 40, 45 years. But in Indian population, they present early. That is one. And also pulmonary hypertension is quite severe, and subvalvular disease, severe subvalvular disease is also quite severe in Indian context. These are some of the important things. And in some patients, particularly, of course, in the last 7-8 years, because we at Jaideva till 2017 used to do around 1,500 balloon mitral valvuloplasty a year. So in the last, even I'm not quoting this COVID as a pandemic as a reason, between 17 to 19, the number of cases dropped by 50%. So there's a definite decline in the prevalence of rheumatic fever. Even in India, among the pockets of underprivileged classes or among slums or tribal areas, still we see those cases. So rheumatic fever in India definitely is more aggressive, more accelerated, more malignant, and occurs far earlier than the Western scenario.
There is another question: how to clinically differentiate and radiologically differentiate between PH and pulmonary venous hypertension. So I think you have already said that pulmonary venous hypertension clinically is more of a breathing difficulty, PND, these are the symptoms. When it becomes a PH, fatigability is the more pronounced symptom. And definitely clinically you have to look for a loud P2. Many times both these two can be there at a same patient. So radiologically you need to look for the size of the right pulmonary artery, isn't it, Professor Manjunath?
Yeah. See, pulmonary hypertension, X-ray, in fact, is very informative. If the upper lobe pulmonary veins are very prominent, what used to be called D-Rantler sign, that suggests pulmonary venous hypertension. And your curly B lines, all those interlobar thickening, fissure thickening, that again suggest long-standing pulmonary venous hypertension.
So I don't need to say anything more. Again, thanking you, Professor Banerjee, and others, please take over.
Okay. Thank you, Manjunath, for your very highly illustrative.
Professor, Dr. Banerjee, can I have a small question?
Yes,
just
yes.
to know?
Yes.
If you allow.
Yes,
So
yes, you can ask question.
It's an excellent lecture, excellent lecture. We all have been benefited, not only the postgraduate, but with the senior people are also benefited just by a recapitulation and also by some of the new ideas which he has told in every case. Every case he has shown so marvelously. This is number one. Number two question is, in case of aortic stenosis, you have told many mechanisms of your syncope, and specifically of the mechanoreceptors, which suddenly, due to the huge rise of pressure, which can give rise to misinformation to the cerebral centers, and it can cause the syncope. Is there any role of arrhythmias in this situation for the syncope?
Yes, told already.
Small subset, yes. Transient arrhythmias.
Thank you, sir.
Thank you, sir.
Okay, Manjunath, I express my individual sincere thanks and also behalf of the ICP West Bengal and API West Bengal for your superb teaching. We know that you are a great teacher. You are one of the best teachers in our country, even in South Asia also. Anyway, another request from us that as and when necessary, we'll get your contribution, academic contribution for the physicians and clinicians this part of our country. With these few words, I also express my sincere thanks to Shunib Banerjee